Welcome to another episode of Clot Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director.
I'm Jamil Abdul-Rahman, hematologist from Toronto General Hospital.
We're here to provide you with updates on diagnosis and management of thrombosis, featuring interviews with authors of recent research publications and highlights of education programs from Thrombosis Canada. Thank you for joining us for this episode.
In this episode, we will be discussing a recent paper published in the journal Research and Practice in Thrombosis and Haemostasis, entitled Anticoagulation Stewardship, Descriptive Analysis of a Novel Approach to Appropriate Anticoagulant Prescription, with co-authors Ryan Kerzner and Dr. Maral Koolian. Ryan Kerzner is a pharmacist at the Jewish General Hospital in Montreal, where he has worked since 2008. He officially joined the Center of Excellence in Thrombosis and Anticoagulation Care in 2019. In CETAC with Dr. Koolian and two other thrombosis pharmacists, he was involved in the development of the Anticoagulation Stewardship Program. And Dr. Maral Koolian is an assistant professor of medicine and the director of Adult Thrombosis Medicine AFC program at McGill University. She is a member of the Division of General Internal Medicine and the Center of Excellence in Thrombosis and Anticoagulation Care at the Jewish General Hospital. Her main research focus is quality improvement principles as they apply to venous thromboembolic diseases and anticoagulation management. Thank you for participating in our podcast today.
Thank you guys for having us.
Yeah, thank you.
So I'm going to start by asking you if you could tell us a bit about what is anticoagulation stewardship and why is it important?
Great. So yeah, this is something that I should probably just preface by saying I actually have I do have an internal medicine background where I always had an interest in anticoagulation as really a focus on VTE, but I'm also an antibiotic stewardship program. And when we had the opportunity, when the CETAC department sort of recruited the three pharmacists, we kind of, we were sitting around having discussions on sort of, what type of quality improvement, what type of work can we actually do? And with, I guess, my experience with antibiotic stewardship and
Ryan, it was really also like, what is the role of an anticoagulation or thrombosis pharmacist? This was not something that was sort of predefined, pre-existent. We don't see so many thrombosis or anticoagulation pharmacists in the hospital milieu, at least in Quebec. So this was really kind of brainstorming, what should this role be? What would our pharmacists, be doing to provide good clinical care, value-added care to patients and to the physicians that they're working with. So that, slight kind of like small interruption, just to say, we really had a blank slate to really define this role in our hospital.
Yeah, exactly. And when we sort of know, and I guess from my experience, knowing the success of antimicrobial stewardship, which has been around now for 20, 30 years. And there's programs really running across all across North America and the world, really. We thought, hey, we know that anticoagulants are, the types of medications that are associated with errors and, associated with harm if they're not used properly. Why don't we try to sort of adapt that program and see how we can apply this to anticoagulants? And that's sort of how it came about. And, we kind of mirrored what our antimicrobial stewardship program was doing. And, instead we said, well, let's just apply this to anticoagulants.
So how does anticoagulation stewardship work at your center, and which disciplines are involved in the stewardship team?
Yeah, so on our day-to-day, usually what we do is we'll print a report of all patients in the hospital receiving really therapeutic anticoagulants. So at the time that we initially started, we really just focused on, there's about 9 or 10 wards here at the Jewish General that don't have a clinical pharmacist. So initially we focused on those wards only, although since then we've now expanded to the entire hospital. And what we do is we print that report. We have a list of every patient who's receiving an anticoagulant, and we go and review them. And so that involves, looking at drug interactions, looking at their renal function or hepatic function, and all the types of things where we feel that we can potentially interact. Even looking, for all patients on warfarin, could they be candidates to switch to DOACs? And we also, on top of that, we also look at all patients who have, let's say, their anticoagulations held in the hospital. And, for various reasons, let's say they were held because, they came in for bleeding or because they had some invasive tests or, OR planned or something like that. And maybe, it was just an oversight that it hasn't been resumed. So we would kind of look at really all of that. And, we sort of started out with a little pilot project, and it was just from the beginning, we're like, wow, there's actually a lot of work here. And and we've expanded on that ever since.
Great. So could you tell us about the descriptive cohort study? Who did you include and what were you looking for?
So it was sort of, it was kind of serendipitous timing. There was a RFP, from one of pharmaceutical companies saying, looking at quality improvement in fibrillation and anticoagulation. And at the same time, we were developing this notion of stewardship in the anticoagulation realm. We didn't know of any other group doing this. Though the Anticoagulation Forum subsequently came up with guidelines as to how to put forth an anticoagulation stewardship program, this was not yet even available at the time. And so while we were building our own program and trying to really define, like in question one, what is anticoagulation stewardship, we saw this RFP. We said, hey, why don't we, define this, build this, create this, and take advantage of this opportunity, study this, maybe get a bit of funding to support us also, because this is something that we were putting together kind of on our own. And so we designed this study. We said, we'll put together our anticoagulation stewardship team. It'll be a multidisciplinary team. We have 3 pharmacists, each with their own sort of complementary backgrounds to thrombosis and anticoagulation, one from Emerge, Ryan from internal medicine. So that's Nikki from Emerge, Ryan from internal medicine, and Helen from cardiology, and myself as a physician ally. We also included our clinical nurse educator. And so we built this kind of team program. And this was our intervention, if you will, from a study perspective. We launched it, like Ryan said, we sort of did this pilot to see, is there even a need, right? Because anecdotally, we felt there was, but we didn't have any numbers to support this. So at the time of the RFP, we already had a small amount of data. I think it was 1 month or something. And so we kind of submitted a proposal to say, look, it's been a month and this is what we found. We want to, do this over 6 months and then go back and look at what are the results of a program like this? Like, what are the proportion of patients that we are actually exacting a change for? What proportion of these prescriptions are poorly prescribed, and really describe in a large tertiary care center what's going on. So that was our study. And that's exactly what we did. Our aim was to determine the proportion of accepted recommendations on inappropriate anticoagulant prescriptions that we had identified from the treating team. And the population that we included were basically anybody who was on a therapeutic dose of any anticoagulant admitted to our hospital, who was on one of the non-clinical pharmacist staffed units of the hospital. So that could have been at the time geriatrics, oncology, family medicine, cardiology, various surgical units. And so kind of a real, diverse and representative group of patients for a tertiary care center. And so we included all these patients. If you were on prophylactic dosing or intermediate dosing, we tended to exclude you. And what we were looking for was really, is this patient's anticoagulant prescription inappropriate based on Canadian best practice guidelines? And if so, we recommend a change. And will that recommendation actually then lead to a change? So that was the study.
Right. And I understand. So of the reviewed prescriptions, 64% generated a recommendation. So what kind of recommendations were being issued?
So recommendation categories, as we liked to call them, could have been dose adjustment, drug interaction, and this could be warfarin or a DOAC, right? And those were actually our most common areas for recommendation. They could have also been temporary interruption. As Ryan mentioned, if somebody had their anticoagulation held for XYZ reason, they would still get audited, quote unquote, audited. And if it was inappropriately interrupted, then we would, recommend that it be restarted, or vice versa. If they were going to have a procedure, similarly, lab monitoring. So you're on a DOAC, we don't have a creatinine in our hospital, that's documented. We get a creatinine. So, there are various categories, and Ryan can kind of speak to them more as to how they were defined, but essentially these were the types of things that, types of recommendations that we were making, and hoping to enhance the prescription with.
Yeah, so a lot of that was really So, I mean, look, you still have a large number of patients on warfarin. So, there was a lot of warfarin adjustments and, sort of that, you become good at that. And warfarin is not, it's not easy to manage when they're hospitalized and it kind of gets all over the place and they're on antibiotics and they're on this. So, we sort of took over that management, I shouldn't say take over. We aided in the management and that, but, and then you have, all the patients on DOACs, for instance, who are just on an inappropriate, let's say, reduced dose as an example. And that's quite a common problem, especially with, you see it a lot, especially with apixaban, patients that are on the 2.5 dose when they have criteria to be on the 5 milligram dose.
We know it affects, from real world studies, we know that kind of represents 25% of DOAC prescriptions, up to 25%. So yeah, I mean, it's a huge proportion.
Yeah. And you would find and what's amazing, you would still find, and even in terms of drug interactions, so two main categories of drug interaction types of interventions. So, you would surprisingly still get patients that come in, let's say on a DOAC who are on, one of the anticonvulsants, like let's say phenytoin that are contraindicated. You're like, how does that happen still? But, you still find those, or carbamazepine, or, you get those type of things. But I think, and that's obviously not the majority of the interventions. There, you get a few cases here and there. But the other type, one of the big things we were looking at was also antiplatelet use. And so you have a lot of patients who are on a therapeutic anticoagulant who are also, receiving concomitant aspirin, and we were kind of really looking to see if we can get that stopped if it wasn't indicated. So that was another big source, and these were all kind of, I think valued kind of types of interventions, because if we could, look at decreasing bleeding risks and, things of that nature, of course, we know it's, we're adding some value, or getting them on the right dose of the DOAC, or, things like that. So those are the kinds of things we were looking for.
It's also, to speak to your concomitant aspirin use, it's sort of like a two birds, one stone from a quality improvement perspective also, because on the one hand, you're making the DOAC prescription in and of itself sort of more appropriate. And on the other hand, you're also engaging in deprescribing, which is also an important consideration when it comes to inpatients, hospitalized patients with polypharmacy. So it's neat because this program sort of has extended its arms into different quality realms as well, which has been satisfying to be engaged in from our perspectives. And, if we can help patients, then that's really what we're looking to do first and foremost. So.
And with the stewardship team, was it a one-time visit, or for patients on warfarin, you'd follow them during their stay? How would that work?
Yeah, so what we really actually it's a good point. So we actually followed the patients as long as they were in the hospital. So patients on warfarin, anytime I would reprint the list, or if I knew I had an abnormal INR, a patient who's fluctuating a bit, I'll follow them more closely. So we would follow them throughout. And so look, it's true that some of the patients where we had 10 interventions because we adjusted the dose 10 times because they were here for 3 months or something like that, so that did happen. But what we did, even in all the patients that we actually reviewed, we actually made a point of checking their lab values at least once a week. And so sometimes, even though we reviewed the patient at the time and everything was fine, all of a sudden, let's say they're in AKI, or, they're in, their ALT is rising and they're on a DOAC. Now their ALT, for whatever happened, their ALT is 400, or, and then, we have to intervene kind of thing. So these are things that we followed them as long as they were hospitalized. We continuously followed them.
Well, each prescription from in the study, we report that each prescription had each patient had 1.5 reviews. And that's what that speaks to, the fact that they were reviewed more than once, because our pharmacy team was continuously following the patient until their discharge, which is, a huge amount of work, but they're kind of amazing and they did it, and it's good for the patient.
Right. And it sounds like the treating teams appreciated it. 84% of the recommendations were accepted. So it sounds like generally high enthusiasm for the service. But what kind of recommendations do you find were treating teams not accepting of, that small 16%?
So we did look at that. We didn't include that in our publication, but we did examine that ourselves. So in the end, some of it had to do with the type of intervention we were doing. So there's different types. So either we did, like pharmacists in Quebec, we have the right to prescribe certain things. So I can actually do, let's say, a warfarin adjustment. If I have an established targeted INR, I can do it myself without getting countersigned, as an example. So that's obviously 100% acceptance because it's done. Or if we took a verbal order from the physician, or if, we're sitting there and discussing, they're right next to us and they're like, okay, I'll put it in. So that's an accepted intervention. So, but other times, and especially more at the beginning, sometimes, and especially if it wasn't as important. So let's say they were on NSAIDs, and there wasn't an urgency. I wasn't going to call the physician and say, hey, can we stop the NSAIDs? And I just left it as a suggestion. So either, let's say in my note, or I left a suggestion on our electronic prescriber. And, on certain services, they don't always look as often. So sometimes it was just ignored or not seen, or, same thing, if it was just left in the progress notes, they may not have seen it. So some of it was that. But then, we went back and we kind of looked. About half of our refusals were actually, we found out we deemed to be inappropriately refused, in the sense that either there was an alternative course of action that was done by the treating team, which was equally acceptable. And let's say as an example, so even, like warfarin, there's so many different strategies to adjusting it. And, they may have, they beat us to it, or let's say they didn't see our suggestion, they decided something else, and, and that's okay also. So it wasn't, it was sort of a refusal, but not, it was still okay.
It's what's called appropriate non-acceptance of recommendation. Like, we had this category, and I think, what, to Ryan's point, it's not so much the category of recommendation, it was more the process by which the recommendation was made that would lead to the acceptance or not, right? And like, as far as categories of recommendation, the dose adjustments, Ryan, were the ones that were most difficult to get the physicians to agree on, like the adjustments for that low dose apixaban that's inappropriately low, and trying to convince certain, I won't name which specialist group, just kidding, but certain specialist groups that, even if they look frail, this isn't the right dose to be using. I think those were the more difficult ones, but for sure the process by which we made the recommendation made more of a difference on the acceptance than the category itself.
Yeah. And I think like sometimes, and especially, if the patient came in for a surgery, the surgeon may not want to take on the responsibility of doing an optimization of a patient's chronic med that they're, let's say, well followed on the outside. So that was part of it too. But sometimes what we'll do is, and a way to get an intervention is, at least we'll bring it up to the patient directly, and then have the patient have that conversation with their primary care provider, or their, or whoever else, follows them regularly. And I think there's one other point to bring up. I think that's important with stewardship in general, and this applies to antimicrobial stewardship as well, is that when we make a recommendation, we make it based on the information that we have access to. And so sometimes there was, let's say, a refusal because we didn't always get the full picture. If you don't have the right information that we gathered from the chart, or, and there could have been something that we weren't aware of, and that happens as well. So sometimes, and we would say that our suggestion was appropriately refused in that context, because, and that's just the reality of doing stewardship. We're not doing like a physical assessment of every patient. We're not doing that, we're going based on what the information we're gathering from the patient's chart, and from talking to other healthcare professionals and things like that.
As hard as it is to admit, we're not always right. I think that's kind of the point here.
Yeah, which is okay, and I sleep absolutely fine at night, knowing that as well.
We're open-minded folks.
Correct.
Great. And you also looked at clinical outcomes, so thrombosis, bleeding, and mortality. We don't really have a control group without the stewardship to compare, but is there any data out there that you're aware of that shows improved clinical outcomes with the implementation of anticoagulation stewardship programs?
So it's kind of remarkable since we started, not necessarily since we published, because we only recently published, but since we started, there's actually been quite a number of anticoagulation stewardship programs publishing their results. And by and large, they're like similar to us, where they describe what's been, what the changes that they see in their center. But there was actually one that looked at outcomes, or at least one that I could think of off the top of my head right now, that looked at clinical outcomes. They did not have a control group, but it was a before and after type of study, a time interrupted study where they they looked at a composite of bleeding and thrombosis outcome. This was Dreijer and his colleagues from the Netherlands who designed and published a study. And so their composite they basically demonstrated that with the implementation of an anticoagulation stewardship, the comparing pre-stewardship and post-stewardship era, there was a reduction. This was their primary outcome of a composite of thrombotic and bleeding events. Thrombotic events objectively defined as any thrombosis, venous or arterial thrombosis event, including MIs, based on imaging or a clinical diagnosis. And then for bleeding events, they followed the ISTH bleeding definitions. And so they were able to show that there was a significant reduction in the post-implementation phase. So it's not really a control group, but it's what we have to date vis-a-vis looking at the impact of an anticoagulation stewardship program on clinical outcomes. They also, in their secondary outcomes, looked at all-cause mortality and showed a reduction in all-cause mortality in the post group. But again, that was a secondary outcome, and so I'm not sure, the true significance of it. But I think it's important to mention, and it's definitely encouraging and promising that this type of program is beneficial to patients from the clinical outcomes perspective, which at the end of the day is what we're trying to achieve here.
Right. So it sounds like it was a successful program at your center. Which kind of centers do you think would benefit from an anticoagulation stewardship program?
So, and I should probably just, before answering that, just preface that there are different types of stewardship programs that exist already also. And so I think we were one of the first, at least in North America, to do an inpatient kind of stewardship. And after seeing the results and, we published our study based on 6 months of patient reviews and stuff, but now we've been doing this for 3 years. And so we've seen really the success and the value of this program. And, it's funny, I was talking to Maral last week and we're like, I hadn't been on for a couple of weeks and we had a bit of an interruption in service and it was the number of interventions I did in the week. I couldn't believe, it's eye-opening. So there really is a problem out there. And as we said, these are really high-risk medications that are, when not used appropriately, you can have some problems. So I think there's a role for this, just as there is for antimicrobial stewardship in all types of hospital settings for sure. But there's a lot of this done, and especially in the US, there's a lot of this done in the clinic area where you have pharmacists run clinics who they're basically assessing these patients and making sure they're optimized and looking at concomitant antiplatelets and the drug interactions in their labs and things like that. So stewardship is being done, and this is really a growing field. And I have to say, the Anticoagulation Forum, they have a whole they have an entire site dedicated to this, and they're seeing the different programs that are popping up in the hospitals. Where you even do stewardship and you look at the management of HIT and the management of reversal, and there's enormous cost savings as well associated with some of that stuff. So their data is really coming out now. And, I have to definitely give a shout out to Allison Burnett for sure, from New Mexico, who she is she's in charge of the Anticoagulation Forum. And, she's really pushing this, and this is really a growing field. And so, there's a lot of that. And, just to add to that.
Editorial, right? Dr. Barnes and Dr. Burnett actually published an editorial for a call for action for more stewardship programs. So, this is something that's really moving forward, as Ryan says.
Yeah, and they're getting support from the regulatory agencies, especially in the US, because this is still kind of new in Canada, at least, but in the US, you have the FDA, you have the CDC, and you have their accreditation bodies that are sort of really getting behind this. So it's going to be so interesting to see what types of groups are doing this, and we even had, Maral and I, we gave a presentation for Grand Rounds on the stewardship program. And there was someone from our family medicine clinic that was there, and they thought of the idea of starting to implement as a resident, a medical resident project, to start implementing in their family medicine clinic, to start doing stewardship, which is phenomenal, and so there's really room for this in all facets of it, from inpatient, outpatient, and clinics, and even on the community pharmacy level. Like there's a role to play, and as I said, we still keep saying we keep seeing the same types of problems coming up, and so there is definitely an issue that needs to be addressed. And I think stewardship is just one of the many tools that's available that I think that has a significant role to play.
What challenges did you come across in setting up the anticoagulation stewardship at your center, and what advice would you give to those interested in setting up a program at other centers?
So, look, we were lucky. Like for us, it was just the opportunity came when the opportunity arose, and we were discussing this. One of the key things I think is to get sort of your hospital administration, like sort of the leadership's commitment to this, because one of the big problems is the ongoing funding. So we're actually operating with a 0.5 full-time equivalent position right now, which is actually not funded by the hospital. It's actually funded through money coming into our CETAC, our thrombosis department. And so that's something that we've been, that we're going to, we think we have enough data now to sort of back up and say, hey, there's value in this hospital. We want to fight. And like, if you give me a full-time position, I'm going to run with it. There's a lot of work to do. So so I think that's an important thing, get your administration on board, see, and to get that commitment, because we know that the program works. And then it's just to make sure, and we hope to be able to continue doing this for years and years and years. And as I said, we've expanded now. So we look at prophylaxis now, and we look at all types of things, and there's a huge role to play in that, that's one of the things. I don't know if Maral, if you have other.
Oh, I think I agree. I think we didn't face so many challenges while setting up and starting. I think our challenges came rather in ensuring sustainability of the program, and I think in part we didn't engage our stakeholders, our sort of hospital administration stakeholders, our financial stakeholders, to get buy-in earlier on. And so in retrospect, that's something that, it's a lesson learned, and it's something going forward that's on the radar. So I would say, like, as far as challenges and barriers, that's definitely the biggest one, is to ensure the sustainability of this program. Like we believe in it. We've shown, change, and we want to continue to build on that, to sustain that change and grow, right? And so as we grow, things get expensive. And so this is the part where we have to work to demonstrate to the administration to get buy-in and be able to keep going forward. That being said, we continue to expand because we do believe in it, with or without the financing. I mean, we have to remain realistic, but on the other hand, we're not going to lose momentum at this point, because the hospital appreciates, like as Ryan said, also the program is recognized now. I mean, Ryan didn't mention it, but they get phone calls all the time, unsolicited calls saying, hey, I have this patient on this DOAC, like, what do you think, or whatever. So clearly there's recognition of this program within the hospital and of our pharmacists who are really spearheading this. And so we just kind of want to keep that momentum and keep going. And so we'll have to figure out a way to prove our worth, right? To speak to administration. And that's really kind of been our major challenge, I would say. I can't think of much else. Like I think we didn't expect to be as appreciated as we were. Like when we first set out, we thought barriers to implementation would be that a lot of physicians would be resistant to changing prescriptions. Like that's a big ask from a physician, right? And sometimes you're sort of like, well, I'm not going to change this prescription because I'm not the one who prescribed it. So now I don't want to take, ownership on the discharge prescription of a changed dose. And interestingly, these were not so many of the issues that were encountered. And so, assumed barriers did not truly manifest, and yet certain barriers that we didn't anticipate manifested. So
in the publication, you mentioned that you were planning further study to determine clinical outcomes among patients with accepted stewardship recommendations compared to those who refused recommendations. Do you have an update on the status of that? Were you able to take that on?
I guess, let's rewind back to number 8, another barrier, obtaining data. So for us in Quebec, unfortunately, our medical charts don't communicate, or our electronic, our EMRs don't communicate from one center to the other from the GP's office. And so we're very limited in the type of retrospective data that we can obtain. So, for example, if we would want to track patients who might have had a thrombotic or bleeding event post-discharge, they would have to return to our institution for us to be able to track that. So the best way to do this is prospectively, and you would only have data for the duration of the admission. So this is what we're working on, setting up now, but it's obviously more labor intensive to set up a prospective study than a retrospective study, but we want to report accurate findings. We don't want to, have huge holes in the data, because that's not helpful to anybody. So that's where that's at, a challenge.
But we had other ideas as well, because we were also looking at, because we want to share our experience, and we want to, sort of make it easier for other people to at least develop or think about developing a type of stewardship program. So we were brainstorming on other ideas, and we thought, what if we just published, a sort of a kind of editorial basically on our a sort of what our, kind of look at what was involved in, in developing this type of program, and the personnel, and really to see what were sort of the day-to-day problems and the unforeseeable things to sort of help other people, if that could be, of some service to others that want to do this.
We've also, as Ryan mentioned, we've expanded into our non-acute care affiliated centers for our institution. And so we'll definitely, we're looking at results from stewardship outside of the acute care setting, still within either rehab or long-term care facilities. And so we'll see if there are a larger proportion of inappropriate prescriptions in those types of settings than within the acute care hospital. Maybe that's an area to focus on or target. And so that's in the works. And then we're also looking at prophylaxis within our hospital, thromboprophylaxis. And we've started a stewardship program, because the original stewardship program was set only on therapeutic dosing. And now we're looking at prophylactic dosing, and we'll see if there's, again, a large proportion of inappropriate prescriptions, and this is yet another a target to focus on and to spend resources on. And ultimately, the hope would be, like antimicrobial stewardship, which is an accreditation in Canada, ROP, the hope would be to sort of make this mandatory for hospitals, and that, and so the more we engage in this, the more we put out there for everyone else to see and engage with, the more we can assure the sustainability and longevity of this program, and hopefully make it an official kind of Canadian accreditation standard for all centers. And that's really the ultimate aim, the overarching aim, if you will.
Okay. Is there anything else that you'd like to add that we haven't touched on today?
Definitely. Well, just if I can add one point, I think, and I hope I'm so happy, and thank you so much for inviting us to do this podcast, because, we want to sell this. We love, we're so proud of what we've done, and we want to scream on the rooftops and get other people involved. And, we already had another hospital not far from us here in Montreal that already reached out to us, and they were interested in developing the program. And so really, if people do want to reach out to us, we're more than happy to meet with you guys and sort of to share our experience. And, if there's a way to, any way in which we could help, we would love to help, because, we as I said, we definitely believe in what we do, and we think there's definitely room for this to be expanded on in Canada for sure.
And to your earlier point, it sounds like it's not just acute care. It's all centers that could potentially benefit from this.
Which centers would benefit? Every center, right? Like that's
yeah.
the question exactly. And so,
thank you both. It's been great to have you on the podcast today. Really enjoyed the conversation, and it's really interesting to see this developing. Like I said before, maybe we should have further conversation about what Thrombosis Canada can do to support this too. Thank you again, and I want to thank our listeners for listening again to Clot Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. And if you have any recommendations for future podcasts, please send them to us at info@thrombosiscanada.ca. Please subscribe to this podcast so that you're notified about the release of new episodes. And don't forget to check out our website for education programs, clinical tools, and guides, including information on our upcoming annual meeting, which will be part of Vascular 2023 in October. Also, please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis. Thanks again.